Okay. My name is Roham Zamanian. Thank you, Lori, and thank you to the Wall Center for, I think, this provocative meeting. I would probably say that the most important thing that comes to my mind as maybe a conclusion thought for today is as a clinician and as a pulmonologist, we see a tremendous development and breadth of information in terms of autoimmunity and inflammation, specifically to pulmonary vascular disease. But I still feel like we don't have a roadmap in terms of the application of that science in a uniform, harmonized way to our patients. And I think that Marc and Paul and many others have been on the calls to do deep phenotyping, and I think that's been talked about a lot today. I think that that for me as a clinician, and maybe someone in the field, that we need to bring that to fruition. I think that's probably the next step, is that what tools do we use in a validated, standardized fashion across all forms of pulmonary vascular disease to understand these patients from an autoimmune and inflammatory way. Whatever the aha moment for me was looking at Dr. Trapnell's presentation of PAP, where the histopathology was so similar between those three cases, and you would only recognize them by their genetic, genomic, or immune signature, what case was what. And I feel like less so with connective tissue disease, but I really wonder whether some of these idiopathics, which we don't know the cause of, and for us, the drugs and toxin patients, and even some congenitals, whether we really understand their immune and inflammatory milieu. So I think there are movements from the NIH to understand this better, but I think it would be very helpful to approach that in a standardized and harmonized way.
Well, I'm Marc Humbert from South Paris University, and I enjoyed your talk, thanks. In terms of autoimmunity and interventions, I think the good news is that when you see a patient with clear lupus erythematosus or clear mixed connective tissue disease, that's usually not a problem to decide to initiate a combination of cyclophosphamide plus steroids. When a patient has scleroderma, we never use immunosuppressant, and we really look forward to your results. What is your primary endpoint? Is it hemodynamics?
Don't ask.
I don't ask.
Look at ATS abstracts that are coming forth.
Okay. Okay. Wow. Okay. And in idiopathic PAH, we never consider immunosuppressants or steroids unless there is a clear comorbidity, which is not idiopathic anymore usually. So a word of caution regarding cyclophosphamide. We have published early this year that all alkylating agents can damage the pulmonary veins, and we have several cases of pulmonary veno-occlusive disease in patients receiving cyclophosphamide or mitomycin. But we know how to use cyclophosphamide in autoimmune disease, pulses, not too many, and with addition of mesna or some kind of anti-cyclophosphamide-induced side effects therapy. So at the end of the day, I think we need data like your data, and regarding use of immunosuppressive drugs or steroids, usually only in specific well-phenotyped lupus or mixed connective tissue disease.
Okay, thank you. My name is Paul Hassoun from Johns Hopkins. I'd like first to thank and congratulate the organizers from Stanford, Marc, Roham, Lori, and everybody else. This was a really amazing meeting. I thought I knew a little bit about immunity and inflammation. I come back home very humbled, not knowing very much. This was a little bit overwhelming. The other thought I had is that I don't want us to stay as blind observers with, the picture of the big elephant, and we are either T lymphocyte-centric or endothelial-centric or fibroblast-centric. And I think there has been enough research now that to get our act together. I'm also struck by the fact that there are specific therapies that increase BMPR2 signaling. And I think this is should be an anchor for us, because this is one signaling pathway that is extremely prevalent in familial cases, but also in sporadic PAH. Whether they have the mutations or not, we know that BMPR2 signaling is down. And since we have either Tregs or FK506 drugs that can upregulate that system, I think this is where we should regroup. Lorinda, Lori, thank you for mentioning that we have not targeted inflammation yet. And I would like to echo Marc's comments on the only times we've seen immune modulators affecting PAH and in a dramatic fashion is in mixed connective tissue disease or in lupus, or spontaneously, really. And sometimes in HIV when they're treated with antiretrovirals. So there is something about immunity and this disease, but clearly not for scleroderma. So these are my thoughts. I think that it is time to target immunity. I also, for the past 20 years, I've had this cystic fibrosis model. We've had the gene CFTR discovered 20 years before any form of therapy came out for cystic fibrosis with ivacaftor. And I think we're close to finding something to regulate BMPR2 or just signaling, and maybe this is where this interaction between endothelium effector cells and immunity comes in place, and this is what we should focus on. And more importantly, and as someone mentioned, and Norbert mentioned it earlier today, I think collaboration, this is what is lacking in our field. We are working in silos, and we really need to have more conferences like this. So Stanford Group, really thank you very much and congratulations.
I have a couple comments to your remark about scleroderma. So it's true that we're not seeing any benefit in scleroderma PAH thus far from immunosuppression, but it's also true that we don't have any drugs that are approved for the treatment of scleroderma in general. And these patients tend to be less responsive to immunosuppression unless they have active myositis or actively progressive interstitial lung disease. So I think that's where the issue is, maybe not so much the PAH related to it, but the disease in and of itself because of the fibrosis and the multiple pathways that are involved. We're just not targeting the right area, I think. The other point I wanted to bring up, though, that I think hopefully gives us hope. Marc, you had presented your data on looking at patients who had undergone lung transplant, and they're, expressing large amounts of various cytokines and inflammatory markers. And these are end-stage patients who are being transplanted. So I think that tells us, well, there's still inflammation going on even at the end, and presumably this is in patients with scleroderma-associated PAH as well as idiopathic disease. So maybe if we can just target the right cytokines and inflammatory markers, we will get there at some point.
Yeah, and Paul mentioned HIV, and when you know the cause of pulmonary hypertension, it's always good to target the cause. For example, HIV indeed, and also lupus when you can intervene on the inflammatory reactions, and also in congenital heart disease when you can close the hole before pulmonary hypertension is too high. So I think it's quite interesting that you have early interventions more active than late interventions, and maybe in scleroderma, the good thing is to screen and intervene with what you can do. I mean, you presented your data in the Blue Journal. Active treatment for pulmonary hypertension seems to be very efficacious when the patients are not too advanced. So it's a positive thinking.
I'm amazed that we have not been thinking, in addition to the early intervention, about diagnostic, mechanistically informative late interventions in those patients that we know are going to be transplanted. Imagine that you take a patient that is on the transplant list and you give that patient rapamycin. And you now have the explanted lung. And you can now compare that on any level you want, genomics, cytokines, whatever, with those that have not been treated like that. That's a suggestion that I wanted to throw up for the panel. Mm-hmm. The other comment I have is, as we are really, interestingly, the entire community, searching for novel treatments and are overtly or covertly disappointed to some degree with the drugs that we have been using, are being using. Is it not time? Everybody is talking about subgroups of patients to make an effort to really immune phenotype our patients, and that can be a panel that can be, discussed with you as the experts. But perhaps there is such a patient that is, or type of patient that is more, has a greater inflammatory burden, and that would be perhaps a patient that would then respond to that kind of now really targeted therapy in this sense. And so I think we are there. We can do that. I mean, I can see that we know about a patient that has congenital heart disease associated pulmonary hypertension, that's a patient who has high interleukin-6 levels, high interleukin-1 levels, maybe has high levels of leukotriene B4, and on and on and on. And all of a sudden, this particular flavor suggests perhaps one particular form of therapy.
Could I just answer to part of that or add on to what you're saying, Norbert? I think that's exactly my point was earlier. But I also think we have to think about some of the finer details of that. Alan is sitting behind you. Alan and I did a 48 cytokine, chemokine exploratory work together where we collected 300 patients and asked for Sheffield for some of their patients. And boy, we realized the profiles that we measured from the same cohort or similar cohort of patients across the pond were different because our processing of those blood samples is different. So, I think that this might sound like a very minute detail, but I think that my point about harmonization was we need to think about the levels of harmonization and technologies that we could use and in a collaborative manner to set aside some blood or tissue for analysis from all centers that are interested in that. My second point was, and I wonder what Lori and others here think about, it's becoming more and more difficult to demonstrate therapeutic effect in pulmonary hypertension, certainly without blowing the budget on morbidity and mortality trials. So when we think about immune therapies in the future, I think there probably may be an immune signature of response, but also we need to be thinking about the endpoints that we would be studying in these patients from both an immune and a disease profile.
I'd like to also get back to the model that Bruce presented, because I think it's very instructive here, as you guys have pointed out. That is, in PAP, it looks histopathologically indistinguishable, but there are multiple causes, including genetic and immunologic causes. It could be the same thing for all of the cases of pulmonary hypertension, PAH, that look histopathologically indistinguishable, where there is a common molecular cause, which is either an immunological or a genetic defect in BMPR2 signaling pathway. I mean, that's what happens with the PAP. It's heterogeneous. You've got autoimmune cases, you've got genetic cases, but they all converge on a pathway, a single pathway that is broadly expressed and active, but the disease is manifesting in the lung with the alveolar macrophages, with a single signaling pathway. So we don't know exactly which cell type is critical in the lung in the BMPR2 haplo. We do know that it is haploinsufficient, and there are very few genes that are haploinsufficient and disease-causing, which means that it is going to be very sensitive to the dosage. And so are some of the immune-mediated causes of the disease, especially those that look histopathologically very much like the genetic causes or the idiopathic causes, are there some of those which could be, for example, autoantibodies against BMPs or BMPR2 or some other that is actually lowering the activity of that pathway only about 50% to the level that we know genetically can predispose in a significant way to the disease. So is that a possibility for a unifying hypothesis for at least some of the immune-related diseases where it is converging on, for example, so has anybody looked to see if there are autoantibodies to the ligand, the BMP ligands, or the BMPR2 receptor, or the other subunit of the receptor? Because those would be a simple and straightforward unification of at least some portion of the immune-mediated cases. In those patients that have immune, the autoantibodies, is anything known about how those arose, or no? Okay.
Just a quick reminder, if you're taking the shuttle, you probably should leave right about now. Otherwise, I think we can continue if people still have comments.
Would it be too risky to try to work on some of the targets in oncology? In oncology, there's an interest, obviously, in checkpoint targets, such as PD-1 and CTLA-4. Would it be too risky to consider trying to target those things in the opposite direction for this disease?
Yeah, we discuss this with oncologists at the Cancer Institute in my university, and we still need to understand better what we play with. Right now, we discuss it, but we have not decided yet to intervene on those pathways.
Marc, could I ask a quick question of you? Do you think we're at a place now in this disease where patients on triple therapy who are burning to get a transplant, but there is limitation to organ availability for sure, that our maybe responsibility as clinician scientists in this field is to really begin to think about transformative therapeutics in those patients? Are those, no longer are we talking about placebo-controlled trials in treatment-naive patients, but triple therapy patients have a pretty poor prognosis as well over a long period of time.
Yeah, the story is not over. And when a patient is on triple combination therapy, we know that the future is not bright. So we really need to consider to have add-on therapies on top of these triple. We need the right endpoints, the right phase 2, the right phase 3, but there is room for innovation for sure.